This is the third lecture about medical mycology, talking about miscellaneous fungal infection seen in various group of patients. Some of them immunocompromised, some of them are not immunocompromised because of the invasiveness of those fungi could be seen sometimes in healthy individuals. First of all, we have four filamentous fungi, those which are responsible for development of chromoblastomycosis. This is a fungal infection associated with a changes in the color of the skin with thickening and sometimes granuloma and necrosis of the underlying connective tissue, and sometimes it might reaches the bone and the muscles, causing massive destruction as it is seen in case of mycetoma. Also, we have a state called mucormycosis caused by a group of fungi which are related to the group of zygomycetes, responsible for development of serious fatal condition which is seen now after COVID conditions, and it is called the black mold. الفطر الأسود هو عبارة عن mucormycosis caused by a certain type of fungi. When they are grown on plate produce a dark color pigment. Also, we have an issue called aspergillosis, and this is a group of fungi present in the environment system, responsible for development of white mycosis seen after recovery from COVID, الفطر الأبيض, and mostly seen in cases of RCU fungal infections following COVID infection, and those are mainly caused by Aspergillus fumigatus. A few notes about chromoblastomycosis. This is a chronic localized infection of subcutaneous tissue caused by several species of Nematicious fungi. That is to say, this is a subcutaneous infection, not a systemic, could be localized and associated with from name chromo, associated in changes in the color. Most of them are hypopigmented. Sometimes there is hypopigmentation at the area of inoculation of fungus. This is a hand of a patient developed several hypopigmented nodule. You see he is wasted, elderly man with hypopigmented nodule. Here is a site of infection. Sometimes could be due to a prick or a thorn from a contaminated wound and or a wood trauma, and this is present in all over the world, not related to certain area, as we saw in histoplasmosis and in case of paracoccidiomycosis. It is usually seen in a warmer climate، الظروف اللي تكون بها نوع من الرطوبة والحرارة، and in the jungles mainly when you're exposed to a certain prick. Later on, gradual development of fibrosis, changes in the color as we see in this picture, sinus formation. This is a sheen of patient. We have fibrosis, we have whitening of the area, we have area of necrosis, we have also development of discharging sinuses. Sometimes the muscle are destroyed, even the underlying lesion could reaches down into the bone. Pus is the best method for diagnosis of this fungi. We can take biopsy from the edge of the lesion. We can excise all area and then we do skin grafting. We can use with the excision tibnifine antifungal drug treatment, or itraconazole or posaconazole. This is a new generation of drug, the posaconazole. This is the incidence, how the accident happened. A thorn, shauka, will enter into the area under the skin. This is the subcut area, subcutaneous area, and there the spores will be multiplying inside the subdermal area, get inflammation, development of fungal formation of a lesion, starting with granuloma. Later on there will be pus formation, discharging sinuses, fibrosis, and discoloration of the skin, and involvement of underlying tissue later on if it is left without treatment. This is the chromoblastomycosis. Fair enough for the first issue. We talk about the mycetoma. Few words, very few words about mycetoma. It occurs as a result of trauma. Later on you get formation of a granule under the skin. Sometimes the granuloma will discharge a pus through a sinus tract which never heals, continue to open and enlarge and extend. Later on we will have muscle invasion more distinctly than chromoblastomycosis, and bone invasion. In mycetoma you get damage to the muscle and bone with massive deformity of the limb and multiple sinus discharging all over the leg with a little pain. While in case of a chromoblastomycosis you get mainly fibrosis, thickening and changes in the color. There is no muscle or bone invasion in that massive degree as seen in mycetoma. This is a leg of a patient completely distorted. The bone have been damaged, seen by x-ray, a lot of discharging sinuses, involvement of the whole area of the ankle joint and the whole area of the dorsum of the leg. Here the fingers are saved. If we take x-ray we see there is massive muscle and bone distortion. All these notches are fibrosis and some of them are actively discharging sinuses. Usually this occur all over the world, could be seen in Iraq, needs warm climate, but mostly seen in the United States, South America and Africa. This is an African person, a dark skinned African person. Clinical specimen in mycetoma, mostly we need to apply biopsy in order to achieve good diagnosis. Sometimes the pus could be of use in this condition. Sometimes the tissue will be excised and sent to the laboratory. Either we stain it with a fixed stain looking for a specific type of microorganism, and sometimes we might do it in a form of cultured media and in the mycology lab. Either we use a pathological section or we use a microbiological method for culture and waiting for the spores to be germinated, and later on we will form a special type of colony and we examine it under the microscope. This could occur due to contamination of burn. Sometimes route of entry could be through inhalation of spores and they will go to an area of bone and skin. Sometimes due to ingestion. In case of inhalation of a spore, the lesion will not be in the subcutaneous tissue, will be in the lung. Ingestion, it will be in the abdomen. Surface contamination and trauma, we will get the development of localized skin lesion with deep-seated granuloma and infection of the muscle and the bone with total distortion of the limb. As early as you treat, as early as you get better result with antifungal and wound excitement. Fair enough. Identification, we said microbiologically by colonial morphology of the conidia, by the granules. Some of them will release special type of granules, especially if it is caused by actinomycetes, اللي هي not a fungus. This is not a fungus, this is a higher bacteria. You look for the color of the colony, the size and shape and the texture. Some biochemical reaction could be done also to differentiate the different species of actinomycetes. This is the Damaticious fungi, specific type of colony, fluffy, dark brown colonies will be pathognomonic, called Damaticious hyphae for the mycetoma causing agent. Therapy, the same as that of the first condition, tibnifine, itraconazole, posaconazole, and the duration of treatment with excision of the lesion and continuous care of the wound. Sometimes it requires massive excision and grafting of the area to be involved. So the earlier you diagnose, the earlier you treat, the earlier you get full recovery in case of a small lesion. Otherwise we might lose the limb. The third miscellaneous fungi we will talk about a serious, very serious, obvious clinical condition increasing nowadays in India after state of massive Delta type of variants of COVID. This is called mucormycosis. It is an acute fungal infection. This is the only fungal infection which occurs rapidly, deteriorated within hours. So it is an acute fungal infection characterized by inflammatory vascular invasion and the thrombosis of area of involvement. Main route of entry is via inhalation, so it could enter through the nose by inhalation of spores to be localized inside the paranasal sinuses, maxillary sinus, and they will develop massive inflammation there. It might go to the eye to cause proptosis. Sometimes we might get extension through cribriform plate into the brain, and this usually occur within first 24 hours to cause the destruction of the bone as well as the vessels inside the brain, ending in death. Rare condition occur due to ingestion, so you can get mucormycosis inside the intestine, and to a lesser extent in certain wound contamination. Geographical distribution worldwide, and is usually a disease of uncontrolled diabetes, either type 1 or type 2, and this is also associated with intake of anabolic steroid. Those personnel who are muscle builders using excess anabolic steroid, those people who are of athletic professionals, المتسابقين، السباحين، الرباعين، يستخدمون المنشطات الغير مشروعة. This will reduce immunity, have a steroid effect, and also they cause hyperglycemia, so they end up with development of mucormycosis. It is rapidly fatal because of massive necrosis of blood vessels as well as the bones as well as the soft tissue structure, massive damage to the tissue causing death of the person because it is in a dangerous area near the brain and end up in death. A mucormycosis as a clinical sign start with the sign of uncontrolled diabetes, that is to say ketoacidosis. The patient might have ketoacidosis coma. It will be represented in a form of high blood sugar above 400 milligram per deciliter with rapid breathing, acidosis, acetone smell from the mouth, sometimes confusion and coma. If the patient is aware, not in a state of losing consciousness, he will give us an expression of nasal stuffness, started with obstruction of the nose, then the eyelid will fall down, formation of S-arc, that is to say a dark pigmentation over the nose or the eye or the cheek, which is very dangerous sign, means that the disease has been spread to cause a fatal necrotic and gangrenous patches on the face, starting from the nose or the eye, extending through the complete loss of the zygomatic bone, and they might reach to the brain within hours. Characteristic of a mucor infection have, we repeat it again, affinity for arterial invasion, nasal or paranasal sinus infection, direct extension to the brain, and rapid fatality. Even the ENT personnel and doctors could not save the patient if he came late because of rapid massive necrosis. See, this is a cadaver, a person who died of this condition. Look, the fungus have been eaten his nose, and there is a depression here and complete the area of necrosis and the bleeding. The eye are proptotic and necrotized as well. Look, this is an eschar, which is a dark pigment because of ischemic necrosis. And here we see that after cadaver have been cut, we cut the head here as we do in the forensic medicine, بالطب العدلي. تتقطع الجمجمة. Look inside the brain, you get complete necrosis here, and there is loss of brain tissue, damage of a blood vessel. This is complete bone erosion and vascular invasion and necrosis. This is an intact area. This is an intact. This is a perforated bony area with massive vascular necrosis. This is completely fatal, sorry. Angioinvasive damage with bone erosion of the brain extending from the eye and nose directly into the brain. This is a biopsy showing the fungus. It caused the death of this patient. We have a wide, non-septated, there is no transverse septation, very little, and ribbon-like structure. Those are the cause of death of this patient seen within his brain tissue. And usually they are wide, broad-based, non-septated hyphae, ribbon-like, just like seaweed. فطريات تشبه أعشاب البحر. Here we have the culture. After we culture them, we see under the microscope a sporangia, rounded sporangia. This is sporangia 4, حاملة الأبواق, and there is no septation. And inside this sporangia we have a large number of spores which are available and have been available here in a large number. يعني هاي الحافظة تتشقق وتطلع منها أعداد كبيرة من السبورات تكون مسؤولة عن ال development of infection there. Treatment طبعا this is very rarely produce a benefit. Most of cases die within first 24 hours. We have a rare survival in this condition, and we should look very early for this disease to be diagnosed from the beginning. Just the patient sometimes feels only tenderness over the paranasal sinuses. He is diabetic, exposed to some sort of petrified soil or tissue, so we have to be careful and send him immediately to ENT. Start with antifungal drug, give insulin with the IV fluid to control diabetes and ketoacidosis, take urgent biopsy, send for the culture, and we start with referral to ENT to do surgical deprivement with the cover of amphotericin B. So you should be very careful in catching the cases early, which is usually not happen in routine practice in medicine. We have a case, have a lymphoma, a treated lymphoma. He has been cured from lymphoma. Unfortunately he started to have proptosis. كان الجفن الأيسر عنده هابط فقط وألم خفيف على منطقة الجيب الأنفي الأيسر. We start him with the treatment with amphotericin B. He entered the hospital. He did very well on amphotericin B. After 1 week he started to deteriorate and he died. In spite of early diagnosis, the disease is uncontrollable in certain cases. Unfortunately, we lost him. He survived lymphoma. He didn't survive mucormycosis. So we have to look for early diagnosis. The last and the most important thing about this is the aspergillosis أو الفطر الأبيض المشاع عنه حاليا. الفطر الأسود هو الميوكورمايكوسيس اللي untreatable in most cases, while الفطر الأبيض هو الأسبرجيلوسيس. Aspergillosis مصطلح شائع هو الرشاشيات, just like a throwal of a water اللي يرش بها الحدائق because of its shape. This is a variety of disease start from mild allergy due to inhalation of a spore to a severe massive pulmonary infection of the lung with cavitation and formation of aspergilloma, which is a fungal ball localized inside an old cavity inside the lung, for example an old TB cavity or direct trauma to the lung, and you have a cavity later on to have a super added fungal infection. Later on we have also a condition associated with otitis externa, and patient develop bacterial infection of the ear, discharging pus later on to be contaminated by fungal infection, and this will never resolve. Continuous treatment, excision, we go to ENT and we treat the patient, we give him antifungal ointment, sometimes systemic treatment form of tablet, and the condition will reoccur. So most fungal infection, you should prevent rather than treat, because they will recur with massive catastrophe. Infection of the eye is commonly seen in form of eye ulcer, infection of the sclera, sometimes involvement of the iris, sometimes you might lose all the eye. It occurs usually after cases of eye trauma and serious contamination by dust or certain fungally contaminated spores. In meninges, we get fungal meningitis, formation of a certain lesion inside the brain, pressing the meninges, just looking like meningioma or a cancer inside the brain. Once you open and excise the lesion, you discover it is a fungal ball inside the brain. Sinus infection, the same event occur inside the sinuses. You develop a ball on X-ray or a CT, look like a mass. You excise this mass and send it to the laboratory. You say that this is full of fungal hyphae. A blood streams rarely occurring because of a big size of the hyphae of this fungus, and this occur only in case of severe massive angioinvasive type of Aspergillus infection, and it's usually an end state of fatal fungal infection caused by Aspergillus when you have a massive damage in the lung, bleeding. Some patient cough the fungus outside the body in a form of tuft of fungi going outside with sputum, end up in massive pulmonary bleeding and death. A clinical type of pulmonary disease could be allergic. We mentioned that before. You get allergy because of inhalation of spore. This is a simple condition. Fungal ball, localized granuloma inside a fungal cavity, inside the lung. And invasive, we get all destruction to the all lung tissue. Fungal ball is good prognosis because you localize it, excise it surgically, and you get recovery, while invasive type, it will eat all over the lung and you get bleeding inside the lung and massive extensive dissemination to other part of body. If you survive lung lesion, you might not survive fungal infection in elsewhere in the brain or meninges, or to go to the liver or in the intestine, adrenal, anywhere. If circulate in the blood and reaches an area where it localized to produce another infection. All those conditions are associated with some issue of immune compromised status. Those are difficult to diagnose. Why? Clinical symptoms are not specific in most cases. Radiology is not a specific except in fungal ball. You can localize a lesion. A blood culture never positive or seldomly positive because it not reach to the blood unless you get terminal fatal cases. Serology is very useful but seldomly positive in early stages. You need to spend 3 weeks to 4 weeks in case of active fungal disease. Later on you will develop the formation of positive antibody titer inside the blood. The antibody titer will be directed against the growing tip of the fungus inside the body, containing a sugar called galactomannan. So if we have in the serum anti-galactomannan antibodies, this is a very good sign for the patient to be diagnosed with having fungal infection caused by Aspergillus. And a very good test, we have to detect it either in form of ELISA. We have a special rapid test just like that of a pregnancy called lateral flow test. You can take sputum, bowel, bronchoalveolar lavage, or even blood of the patient according to the type of manufacturing company. And you can put a drop of this serum on this cassette. You get 2-line positive, just like that of pregnancy test, to be sure that this patient having anti-galactomannan antibody. Very nice bedside test discovered recently, and they are well applied in most cases of Aspergillus lung infection or elsewhere. If we have antibody in the blood, you can detect them by this lateral flow test. Or you can use ELISA, اللي هي serious continuous dilution of serum with the chromatographic agent, and you get changes in the color in case of positive titer. We need more invasive procedure for early detection. Yes, we need this in a great disparate area. You can do bronchoscopy. You can obtain sample from inside the bronchus. You can use lung biopsy. You can use biopsy from the sinuses. You can use a special swab for ear in order to or from the eye or from skin infection to achieve early diagnosis by culture inside mycology lab. We have in the second floor in medical city a specified mycology lab, and we can do all type of culture. The growth will appear after 3 to 5 days in a form of whitish colony with dark gray, sometimes a gray green center, which is usually referred to Aspergillus fumigatus. This is very common pathogen, but the most common is the Aspergillus fumigatus, Aspergillus niger, and Aspergillus flavus. Aspergillus fumigatus, we said it is the commonest complication after COVID-19 infection of lung. Patient recover from COVID lung infection, and he will die because of Aspergillus infection inside the lung, which is very, very devastating end for a person who recovered COVID. We have Aspergillus niger. This is a dark color Aspergillus produced mainly ear infection. Aspergillus flavus, this is another type of fungal infection, a whitish periphery with a green to sometimes a yellow center. Usually Aspergillus flavus are seen in case of paranasal sinus infection, some also lung infection, and also it causes aflatoxin production and end up in liver cancer at old age because of super ingestion of contaminated nuts, just like peanuts فستق العبيد الملوث اللي مصاب بالفطريات القديم، فيخزن ويباع على شكل مغلفات، فيكون هو مصدر من مصادر التلوث بالأفلاتوكسين. أو حتى الكورن الإذرة أو حبوب الشعير تخزن في أجواء سيئة، تتعرض للرطوبة، ينمو عليها الأفلاتوكسين بشكل غير مرئي دقيق، وينتج العفو Aspergillus flavus ينمو عليها بشكل دقيق غير مرئي، لكن toxin will be very high concentrated when we consume يعني any type of a product contaminated with Aspergillus flavus aflatoxin. You might develop cancer in old ages. It is present anywhere in the world. We said it is a worldwide disease and usually could be seen in the soil, decaying vegetation, any area of decaying vegetation, in case of woods, in case of dumps of grocery، يعني ممكن مكبات مع الخضار المتعفنة قرب الأسواق، الحاويات، الأزبال اللي لا تفرغ بشكل مستمر. حتى لو كان فواكه والخضار المتعفنة في الثلاجة، هذه كلها متلوثة بالأسبرجيلس. فوي mention food here اللي هو petrified food، الطعام المتبسخ. medication ممكن يعيش داخل قطرة العين المفتوحة، بداخل أنابيب المغذيات، pints of fluid if they are contaminated and turbid, inside eye drops, even inside disinfectant if it is not well preserved and contaminated or diluted in water. in air vents في فتحات التهوية، inside septic units, air conditioning system, all filters should be cleaned and sterilized because they are a major source. خاصة في ردهات زرع النخاع العظم ما يصير نحط سبالت وكونديشنات، لأنه تكون مصادر للفطريات اللي هو ميوكور and aspergillus. We must use HEPA filter، نوع خاص من فلترة الأجواء، تسحب الهواء الملوث تعقمه وترجع تضخم. هي هاي لازم تكون negative pressure in order to prevent the dispersion of spores all over the room where we keep the patient with bone transplantation. يكون هو طبعا مناعته صفر، ونعطي أدوية توقف المناعة حتى نزرع له نخاع عظم جديد for 10 days. this environment should be completely aseptic and sterile. مع الأسف الأنواع اللي تسبب infection عديدة جدا، اللي هي توصل حتى 900 species 900 species. slow grower if we culture them we wait for 3 to 5 days sometimes 10 days to get a colony. You get a different color of the colony, fluffy, nice, with elevated edges, and the size, shape, texture, the color, the size of a spore as well under the microscope will verify the type of Aspergillus. We said that moderate size colony with a rounded shape and whitish in color with a green center, Aspergillus flavus. If it is a big size colony with a mucoid edges and a black center, this is Aspergillus niger. If we have it in a form of moderate size colony with a yellowish or a greenish center, this is Aspergillus flavus. This is a macroscopical picture showing the macroconidia with a large number of phyllies مثل أصابع. Different phyllies arise from this conidophore and end up with the spore attached to the stem. The stem is septated, not like that of a mucor. It is septated hyphae. Histopathology is important in certain condition, case of aspergilloma of the paranasal sinuses, or that of meninges, or that of the lung. We see we have a wide septated hyphae, just like a Y shape. This is called dichotomous branching, اللي هو الوايت shape. Several dichotomous branching here. Look for the septation, different completely from mucor, and this is not very wide, ما يشبه أعشاب البحر. This is narrower, Y shape, dichotomous branching inside an aspergilloma. Here we see even a fruiting head. This is a fruiting head, يعني complete full grown vegetative form of the fungus متحول من hyphae طبعا inside the cavity wall of aspergilloma. This is a magnified picture. You see the head, conidophore, phyllies, and large number of spores attached to them. Serological tests we mentioned, we could detect them by immunodiffusion, by ELISA for the specific antigen, that is the galactomannan. So the anti-galactomannan is very good diagnostic procedure. If we localize the lesion, we diagnose it by culture or biopsy, and then we do serological test. After 2 weeks we get involvement by high rising titer of antibody against galactomannan. Another sample be taken after 3 to 1 week, 3 days to 1 week, and still positive and rising titer. We will be sure that it is fungal infection. So we start voriconazole treatment. This is a new drug available in our country, very good in treatment of severe cases of aspergillosis, with or without amphotericin B. We said that amphotericin, we have the traditional one, we have the liposomal one, and lipid soluble one, which is the best one, and very, very nice, applied with little or much less side effect than the traditional amphotericin. We could use also, I didn't mention it here, for mild cases we can use itraconazole, available also in our country. Identification, microscopic, we look for the conidophore and specific shape of phyllies and small finger like to which we have a several number of spore attached to. Also we can do conversation with the patient, ask him about the way he live and the way of his work, where he work, exposure of any type of fungal contamination, type of work, whether he is immunocompromised or not. Third is considered history intake. At last but not the least, we can do PCR for early urgent diagnosis of cases with impending danger. The PCR will give us positive result within 3 to 6 hours, and it is the best for diagnosis of fungal infection. This is the end of our lecture, and this is the end of my 3 lectures about medical mycology. Thank you for listening. Any question, you can attend my room at the unit of clinical and communicable disease in the first floor, and I will answer you with any more information you need about this subject, and we shall explain the rest of the morphological structure of mycology in our practical lab given to you by my colleagues and me next week, and we will see you well and be safe. Thank you very much for attending the lecture.